So hello, good morning, good afternoon and good evening to all our chair speakers and a wonderful audience in different parts of the world. Welcome to ACNS Webinars. The speaker for the first session of today is our honorable faculty from Australia, Dr. Leanne Slater. Dr. Slater is a consultant neurointerventional radiologist at the Monash Health and Director of Training in Radiology with a national leadership role as the INR Network Training Director for Victoria and Tasmania. She previously served as acting head of neurointervention and completed advanced fellowship at the Toronto Western Hospital and Monash Health. Dr. Slater is undertaking PhD at the Monash University, focusing on middle meningeal artery anatomy and its role in chronic subdural hemorrhage. She holds a Master in Medicine Radiology from University of Melbourne and is a fellow of RANSER. An accomplished clinical researcher, Dr. Slater has authored more than 70 peer-reviewed publications in leading journals and has over 3,300 citations. She also serves as an associate editor for Frontiers in Neurology and JNIS Advances and has delivered more than 20 invited national and international presentations, including keynote addresses across the world. She is the coordinating principal investigator for multiple human and pivotal clinical trials in neurointervention, particularly in embolization therapies for CSDH and venous sinus stenosis. She is also deeply engaged in service development and multidisciplinary leadership, having led major initiatives including the design and implementation of state-of-the-art biplane neuroangiography suite and the optimization of stroke and neurovascular services at the Monash Health. We are extremely honored to have her today at our webinars, and today she will be talking about under pressure, the diagnosis and treatment of CSF leaks at the Monash Health. The speaker for the second session of today is our honored faculty from China, Professor Lu Ma. Dr. Ma is a professor and PhD supervisor in the Department of Neurosurgery at the West China Hospital, Chengdu. He is also the academic and technical leader, Sichuan Province Health Commission. He was a previous visiting scholar at the Department of Neurosurgery, New York University Langone Medical Center, and his clinical interests are focused upon management of skull base and cerebrovascular diseases. He is the secretary of the West China Training Base for International Education of the WFNS and also vice chairman of the Minimally Invasive Surgery Subcommittee for Intracerebral Hemorrhage. He is a noted scholar with over 100 publications in SCI journals and holds 4 authorized national invention patents. We are extremely honored to have him today at our webinars, and today he will be talking about using hybrid surgery under the guidance of Electrophysiology and DTI to treat huge AVM in the Eloquent Cortex. The chair for the first session of today's webinar is our honorable faculty from the USA, Dr. Mohammed Abdul Qadir. Dr. Abdul Qadir is a board certified diagnostic and interventional neuroradiologist at the Boston Medical Center and an associate professor of radiology at the Boston University, Chobanian and Avedisian School of Medicine. His clinical practice is focused on imaging and performing neuroendovascular procedures in patients with acute stroke, intracranial aneurysms, intracranial stenting, carotid stenting, endovascular treatment of AVMs and AV fistulas, vertebroplasty, kyphoplasty, and endovascular treatment of pulsatile tinnitus. He is an author with over 200 publications in various peer journals, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable faculty from the Czech Republic, Professor Vladimir Benes. Prof. Benes has held the position of head of neurosurgery in the Central Military Hospital, Prague, and chairman of the Department of Neurosurgery at the First Medical University, Charles. He was the past vice president of the EANS till 2007 and chairman of the training committee of the EANS as well as the president of the EANS. He was the previous head of the neuroanatomy committee of the WFNS along with the Professor Imad Kanan. He is also an invited faculty to various workshops and conferences organized all around the world, and his literary contributions sums up in scores of published articles in various international journals and book chapters. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President Prof. Yoko Kato, I would like to welcome both the speakers, chairs and all the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this podium to our first chair, Prof. Mohammed Abdul Qadir.
Thank you for this introduction, and I would like to welcome our speakers. We're going to start with Leanne, who's really going to talk about a very important topic, the CSF leak. It's unfortunately underdiagnosed and undertreated condition that may affect a lot of patients. So we're looking forward to hear from her about the new techniques of diagnosis and the treatment of this rare but very important condition.
Thank you very much. I'm just going to share my slides. So I'd like to thank the ACNS Webinars for inviting me to talk about the treatment of CSF leaks and the diagnosis of CSF leaks at Monash Health. The Monash CSF team is made up of interventional neuroradiologists, a spine surgeon, neuro-ophthalmologists, interventional neuroradiology fellows, interventional neuroradiology clinical nurse consultant, and we're all part of a monthly CSF MDT where we discuss all these patients, diagnose them and plan their treatments. And this talk really is a culmination of the work that that whole team does. So I want to acknowledge them. And I want to make a particular mention to my current neurointerventional fellow, Dr. Enrique Balvolsky, because he's really been instrumental, not only in setting up this service, but actually in refining our protocols for MRI imaging, as well as our CTM protocols, which has allowed us to find so many of these leaks to get them treated. So just with regards to what we're going to cover today, we're going to talk a little bit about the history of spontaneous intracranial hypertension. We're going to talk about the epidemiology, how they present clinically, what our imaging pathway is at Monash, the different types of CSF leaks that we see, localization of those leaks. We're going to have a look at the treatment, and we'll go through some illustrative cases to really put this knowledge into practice. So if we look at the history of CSF leaks, they really were first described between 1938 and 1953 by the German neurologist Georg Schädelbrand, and he described the condition as hypoleukuria. So it's not a new condition that we're dealing with. Then in the 80s and 90s, Shevink and Morkry began to recognize spontaneous spinal cerebral fluid leaks and intracranial hypertension more frequently, and the JAMA review paper by Shevink in 2006 really marked a big milestone in this condition because this actually educated the medical community on a large scale about spontaneous spinal CSF leaks as an important cause for headaches. Then, following on with this, in 2014, Shevink's team made the breakthrough discovery of CSF venous fistulas as another cause of CSF leak where you couldn't see fluid collections on imaging. That was then followed by a classification system being proposed in 2016, and this classification system included types 1, 2, and 3, and tried to categorize these different types of leaks. Then 3 years later, Richard Farb's team redefined this classification and added a 4th type of leak, and they started to talk about imaging strategies for finding and localizing these leaks. In 2021, Walid Brachinji described the endovascular embolization of these CSF venous fistulas, which up until this point had only been treated surgically. And then in 2023, sacral tears, dural tears were recognized as an additional cause of spontaneous intracranial hypertension. And I'll note that my fellow was actually one of the members on this paper. So that's a little bit of the history. Who gets spontaneous spinal intracranial hypertension? Well, it occurs in about 2 to 5 in 100,000 people, and it's more common in women than men, and the peak incidence tends to happen at around 40 years of age. If we look at the clinical presentation, orthostatic headache is typically the presenting complaint, and it's seen in about 90% of these cases. And what's really interesting is that when you start seeing these patients, the majority of them can pinpoint the exact day that their CSF leak started, because they'll tell you the exact day that they developed this headache. Outside of orthostatic headaches, there's a multitude of other symptoms that patients present with, and you can see some of them listed here, but the other one that's commonly spoken about is this idea of brain fog, which is this inability to think clearly. Patients describe walking around like they feel like their head's in a cloud, and they feel like they've got true cognitive impairment. So at Monash, we use the HIT6 assessment tool to determine how severe the headache is, and we use the MOCA to assess the degree of cognitive impairment. And we don't only use this at the time of diagnosis, we also use this to monitor the response to treatment after we've treated their CSF leaks. In terms of imaging, every patient who has a clinical suspicion of SIH has an MRI brain and MRI spine done. You can see there the sequences that we do in each of these. And essentially the MRI brain is used to confirm the syndrome of intracranial hypotension. And the MRI spine is used to have a look and see, is there a spinal longitudinal epidural collection? And to determine whether it's a wet or a dry leak, because this is what helps guide the next diagnostic step, which is a myelography done either under CT or as a digital subtraction myelography. So if we look at the imaging features of SIH, we'll start with the MRI brain. So the findings on the MRI brain can be summarized by the mnemonic SEEPs. So we see subdural fluid collections, they might be hygromas or subdural hematomas. You get enhancement of the meninges, you get engorgement of the venous structures, you see pituitary hyperemia, and then you get sagging of the brain. And you can see there are multiple measurements that can be done to objectively assess the degree of sagging of the brain. And then in the really chronic cases, you can get superficial siderosis, which typically happens in the posterior fossa. And if you take all the patients who have clinical signs of SIH, 80 to 90% of these patients will have an abnormal MRI brain. Now, the reason that these features happen in the MRI brain is explained by the Monro-Kelly hypothesis. So the Monro-Kelly hypothesis states that the sum of the brain volumes, that's the brain tissue, the cerebrospinal fluid, and the intracerebral blood, is constant and it's maintained through homeostatic mechanisms. So if the CSF volume decreases, because the brain volume is a fixed volume, the blood volume has to increase. And that's what accounts for all of these findings that we see on the MRI brain. For every patient who gets workup for SIH, we perform a burn score, and this is a predictor of how likely a patient is to have a CSF leak, or a spinal CSF leak, I should say. So the major features are engorgement of the venous sinuses, pachymeningeal enhancement, and supracell assisted effacement to 4 millimeters or less, and each of these major features gets 2 points each. The minor features are subdural fluid collections, prepontine cistern effacement to 5 millimeters or less, and mammaropontine distance reduction to 6.5 millimeters or less. These minor criteria get 1 point each, and then the patient gets a burn score. Based on that, they're stratified into low, intermediate, or high probability of having a spinal CSF leak as a cause for their spontaneous intracranial hypotension. So this is just some of the examples of the MRI brain findings, and what you can see here is an example of pachymeningeal enhancement. We can see the subdural collections in the form of hygromas or subdural hemorrhage here. We can see the slumping of the brain with effacement of the superior supracellar cistern and reduction of the mammaropontine distance and prepontine cistern. We can see this marked venous engorgement, another example of hygromas. And this is a patient who had chronic CSF leak and has developed this superficial siderosis in the posterior fossa. In terms of the MRI spine, the key sequence in this imaging is the fine slice, heavily T2 weighted sequence. So we do a T2 space on all of the patients who are being worked up for SIH. And what we're looking for here is this spinal longitudinal epidural collection. And this is an example here of a ventral leak. So typically we'll go through this a bit later, but through a hole in the anterior theca. So we can see what the imaging features are, but to figure out what exactly is causing this leak, we have to look at the mechanisms of CSF leak. So there are three main mechanisms. The first one is a dural defect at the nerve root sleeve, and this often is associated with connective tissue diseases such as Ehlers-Danlos or Marfan syndrome. In some patients, they might have a history of previous idiopathic intracranial hypertension, and they've got a whole bunch of diverticulums. So that's one example of it. The second one is dural tears, typically in that ventral location due to osteophytes, disc herniation, and dystoogenic spurs, which actually cause a hole in the anterior dura through which the CSF leaks out. And the third mechanism is this idea of CSF venous fistulas, where the CSF is leaking directly into the vein, and therefore there's no visible collection on the MRI imaging. So these three mechanisms result in 4 different types of leak which is type 1, which is that ventral hole in the spinal dura due to degenerative disc disease. Type 2, which is a more lateral but proximal nerve root sleeve, which is unrelated to degenerative disc disease. Type 3, which is the CSF venous fistula. And type 4, which is a distal nerve root sleeve tear that happens beyond the epidural compartment. So these are patients who have wet leaks, but the CSF collection happens beyond the epidural compartment. So because of the location of the tears and the mechanisms of the tears, we end up with SLEC positive and SLEC negative division of type 1 and type 2 and type 3 and 4 respectively. Now, we've talked about these 4 types of leaks, but you'll remember in the history I mentioned that sacral leak was designated as another cause for SIH in 2023. Now, in this original paper in 2023, what they found was that sacral leaks were an under-recognized cause of SIH happening in about 6% of patients. The features of these patients were visible meningeal cysts in the sacrum. The patients often had a history of minor trauma, and in this initial paper, all of the patients were women. On imaging, the spinal longitudinal epidural collection was confined to the sacral area, so there was no extension more superiorly. And in this paper, all of these patients were managed with epidural blood patch in a reverse Trendelenburg position to encourage that blood to go down towards the sacrum. Now, just last month in March, this paper was published as a follow-up to that 2023 paper. And again, my fellow was one of the contributing authors. And this actually looked at sacral dural tears in patients presenting with SIH in a multi-center cohort. And the key findings from this paper was that the mean age was 37.8 years, so similar to the demographic of other SIH. In this case, 85% of the patients were women, so there were 15% of patients who were men, unlike that initial paper that were all women. In these patients who had epidural blood patches or fibrin patches, they had complete clinical improvement in 56% of patients. And in terms of imaging, there was complete resolution of those extradural collections in 46% of the patients who were treated. When they were looking for the leaks, CT myelography was shown to more precisely localize the leak more frequently than DSM, with 75 versus 31% localization on those 2 modalities. And in this group, unlike the first group, there were 8 patients who underwent surgery, and these patients had mixed clinical and imaging outcomes. So although we talk about the 4 types of CSF leak, I think it's important to remember sacral leak as a 5th type. So what do we do at Monash to localize the leaks? Well, we divide the leaks into wet leaks and dry leaks and SLEC positive and SLEC negative. So you'll remember that the ventral leaks, that type 1 leak due to a degenerative osteophyte, results in that ventral SLEC. For these patients, and in fact all our patients, our primary investigative tool once we've decided there's a leak is CTM. So we're reserving DSM for problem solving. So in these patients, we would do a dynamic ultrafast CTM, and if it's the suspected leak is above T10, due to the anatomy, shoulders, etc., you should always do CTM. If it's below, if in your center you want to use DSM, you can use DSM for below T10. Patient needs to be positioned in a prone position so that the contrast goes to the front of the thecal sac, and they need to be positioned with their head down and hips up to encourage that contrast to run from the puncture site towards the head, so you can see the contrast flow out of the hole in the theca. If you're suspecting a lateral leak, so this is type 2 or 4, with 2 being a SLEC positive because it's still within the epidural space, and type 4 being SLEC negative because it's beyond the epidural space and the CSF leaks into the fascia and the interstitium beyond the epidural space. Again, at Monash, we do all of these with CTM, but you can do them with DSM. These patients should be in the lateral decubitus position, lying on the side that the leak is suspected, and again with the hips up and head down to encourage the contrast to flow towards the head. If a sacral leak is suspected, as we saw from the previous paper, CTM is better at localizing these leaks. Again, these patients are in a lateral decubitus position, with the difference being that this time the head is up to encourage the contrast to run towards the sacrum where the leak is suspected. If it's a SLEC negative leak, so a dry leak, This is the CSF venous fistula. So on these patients, you've got a high suspicion of a CSF leak, but there's no fluid collection. For these patients, we also do CTM. We do these in bilateral decubitus positions with the hips up and the head down. And in Monash, we do both sides on the same day. So we access the thecal sac, we give contrast, and we tend to image the side with the larger, more irregular nerve sleeve cysts first, and then with the needle in position, we carefully rotate the patient to the other side and repeat the process on the same side. We also give the patient a straw to breathe through during the procedure to create resisted respiration, because what this achieves is decreased SVC venous pressure and increased lumbar CSF pressure to really encourage the contrast to flow from the CSF into the veins if there is a leak present. So once you've found the leak, how do you treat these lesions? In the literature, there's been several things described, and most of these are not just for spontaneous intracranial hypertension, but also for iatrogenic leaks. So the treatments described include conservative, which is bed rest and hydration, and this works in about a third of the patients, but this is typically more in the post-lumbar puncture headaches. Likewise, epidural blood patch is the gold standard for post-lumbar puncture headaches. It is successful in about 2/3 of patients, but what we found at Monash is that in the patients who have CSF leaks that are not due to post-lumbar puncture issues, these patients tend to have a response that is not permanent, and the response tends to decrease with time, regardless of whether we use blood or fibrin. So most patients, even if they have a temporizing blood patch, end up with a definitive treatment if they have a CSF leak for any other cause other than post-lumbar puncture. In terms of endovascular options, as I mentioned in the history, when Walid described transvenous embolization of the paraspinal vein, this became a real emerging therapy, and it's actually become the preferred treatment for CSF venous fistulas in most centers. At our centers, all of our CSF venous fistulas are treated with endovascular embolization, and really surgery is reserved for patients who have failed repeated attempts at endovascular treatment, and we've not had one of those patients yet. In terms of surgery, this is our preferred choice of treatment for patients who have dural defects, be that the ventral dural defects due to disc spurs or due to meningeal diverticular defects. And as I previously mentioned, CSF venous fistulas really would only be reserved for where endovascular treatment has failed, or if for whatever reason it was technically unsuitable. So what I'm going to do now is I'm going to run through some case examples which brings together what we've discussed to cases that we have seen and treated at Monash Health. So we're going to start with the type 1 CSF leak, which is the ventral dural defect. So this is a patient who initially presented in 2009 as a 24-year-old man. He had a seizure, and on the imaging that was done on his brain to evaluate that seizure, he was found to have a left-sided subdural hemorrhage. He had no history of trauma, so he had a CTA, an MRA, and a DSA to exclude a vascular lesion, and no vascular lesion was found. So at the end, he was discharged with no cause for his subdural hemorrhage. In November the following year, a MRI brain and a cervical spine was requested for suspected low pressure syndrome. Now, his MRI brain was reported as normal, noting that his subdural hemorrhage had resolved, and in his cervical spine, which was not a fine sliced, heavily two-tubated system, a loculated cystic structure was noted anteriorly, but this was reported to be an arachnoid cyst. Now, I'm going to show you his MRI brain from back in 2010. And remember that back in 2010, we weren't talking about CSF leaks and SIH the way that we are now. So people weren't, the burn score didn't even exist. So if we do retrospectively perform a burn score in his 2010 MRI, what we see is he gets 2 points for a reduction in his supracella cistern. He gets a point for prepontine cistern effacement. He gets 1 point for reduction in mammillopontine distance and 2 points for venous engorgement. And this gives him a burn score of 6, which gives him a high probability of a spinal CSF leak. So as I said, that's a retrospectively applied burn score. So in the end, he kept presenting between 2010 and 2012 with headaches. He had multiple CT brains performed. All of them were reported as normal. But then in 2021, he represented with the clinical notes of odd olfactory symptoms triggered by straining. And by this stage, we were starting to think about CSF leaks. So he had imaging done again, and what we can see here is that he has this hemosiderin staining in his posterior fossa, which is seen in these patients with long-standing CSF leaks, and you can see that he's now been leaking for 12 years, and we can very clearly see this spinal longitudinal epidural collection on his heavily T2 weighted spinal imaging. So he went on to have both the DSM and a CTM to localize it. And part of the reason for this was that we can see this epidural collection on the DSM, but the exact site wasn't quite identified. However, when we did the CTM, we can see the defect right here. And this allowed the surgeons to know exactly which level to operate on. So he went to surgery, and here you can see that very tiny ventral dural defect, but the source of all his problems. So this was repaired, and all of his symptoms resolved, and his brain went back to normal. So the next case I'm going to show is a type 2 CSF leak. So this is that proximal nerve root sleeve defect. So this is a 40-year-old female who actually presented to us with a history of a few years of this brain fog. She had dizziness, unsteadiness, vertigo, and this vague earfulness, and she reported that it got better whenever she lay down. Over the time, she'd had 2 epidural blood patches with symptomatic relief, but every time her symptoms came back. Her HIT-6 score was 68, so she had a reasonably bad headache, but her MOCA score was 29 on 30, so she didn't have drastic cognitive impairment. This is her MRI brain and her spine imaging. So she has a burn score of 6, again, consistent with a high probability of a CSF leak. And when we look at her spine, she's got this large cystic lesion in the neural foramen at T8-9, and she's got this lateral spinal longitudinal epidural collection. So it's not at the front like the previous one. This one lies more laterally. So with her, we did a CTM with the left side down, and you can just make out here the contrast that's kind of going out of this cyst and going into that lateral epidural space. This was a DSM that we did just to confirm the findings, and here on the CT that we did on the table as part of the DSM, you can see that epidural collection in that lateral compartment in keeping with this proximal nerve root cyst defect. We mark our thoracic surgeries with a coil for the neurosurgeons just to help their counting. And you can see here on the surgical image, this arachnoid that was protruding through that defect in the proximal nerve root sleeve. And essentially, I think that video just jumped, but basically that defect was oversewn to tuck that arachnoid away, and her symptoms went on to resolve as well. So this is the type of leak that we would treat with surgery primarily. The next patient that I'm going to present is an example of a type 3 leak. So this is the CSF venous fistula. So this patient is a 43-year-old female, and she actually had a history of idiopathic intracranial hypertension since 2017 and was seen a neurologist for that. In 2024, she presented with an increased headache, but this was an occipital headache rather than a frontal headache. And she had this vague neck numbness and visual blurring. She also reported increasing tinnitus symptoms, and she was actually referred for imaging query-carotid stenosis versus cerebral venous sinus thrombosis. Now, what I have here is her imaging from 2017 when she was diagnosed with IIH, and comparing it to her imaging in 2024 when her symptoms changed to more low pressure symptoms. And you can see that on her MRI brain, even back in 2017, she's got this effacement of her suprasellar cistern. There's a bit of a reduction in her mammapontine distance. But what's interesting is instead of having venous engorgement, she has these quite marked stenoses in bilateral transverse sinuses. So she was being managed with acetazolamide, dipyramate, and then in 2024, when she presents with low pressure symptoms, she's actually been stopped from the acetazolamide, and on her MR, she now has a burn score of 6, so a high probability of a spinal CSF leak. And the interesting thing with her MR brain is, although you probably wouldn't note these sinuses as particularly engorged, certainly compared to 2017 when they were markedly stenotic, they've enlarged quite significantly. And her spine imaging showed no spinal longitudinal epidural collection. So at this point, we had a strong suspicion for a CSF leak, a CSF venous fistula. So we performed an ultra-fast CT myelography on her, and was imaged in lateral decubitus position on both sides. And you can see here on this scout that positioning that I've been talking about, with the hips being elevated and the head down to encourage the contrast to run down towards the head so that you can see the leak. As I previously mentioned, we perform these with resisted respiration to maximize the chance of the fistula being shown, and you can see here the contrast layering in that right decubitus position, with the contrast then filling that paraspinal vein and heading towards the azygos vein. Now, this paper, also published from Waleed's group, has become the roadmap for endovascular treatment of these CSF venous fistulas, because it just demonstrates all the various ways that you can get into all of these levels. And I think all of us who are treating these conditions have a picture of this in our labs, just to give us the clues of how to find these lesions. And we certainly look at the pre-embolization imaging to try and figure out which is going to be the best route to get to these lesions. So this is this patient's embolization. We came in from below. We've actually moved to doing a lot of these lesions via the through the arm, but this was a higher lesion. This was a T6-7 lesion, so we would come from below for this sort of lesion just due to visualization. And you can see that we get this onyx cast that fills the paraspinal veins entirely surrounding the nerve root sleeve, and also extending into that epidural space just to minimize the risk of recurrence. So her post-embolization course initially was great. She had low pressure symptoms resolved on day 1. She had no headache. She was really happy. However, on day 2, she developed a severe headache, which was worse when she was lying down. And she described the symptoms as being exactly the same as her IIH symptoms that she had before all of this started. We restarted her Diamox, and her course from day 2 to 3 months post CSF venous fistula embolization was that her IIH symptoms gradually worsened, and to try and manage that, her Diamox doses were increased, dipyramate was restarted, but she actually reached a point that her Diamox doses were so high that she was getting really bad side effects of dry mouth, peripheral neuropathies, and photophobia. She also developed new right-sided tinnitus, and interestingly, when we compressed the right side of her neck, we could actually resolve the tinnitus. Now, normally when I perform lumbar punctures for patients with IIH, I would never do it with Diamox on board, but her symptoms were so severe that I wasn't willing to stop it. And even with 1.5 grams of Diamox daily, she had an opening pressure of 26 millimeters of mercury. So if she hadn't been on Diamox, my expectation is that her symptoms would have been a lot worse. We then did a venogram and venous manometry, and this was done within a week of the lumbar puncture. Again, something that I wouldn't normally do if I was trying to demonstrate a gradient across the stenosis, and I certainly wouldn't do it with Diamox, but in this patient I did because of how severe her symptoms were. And you can see that there's almost no perceptible transverse sinus on that right side, and even with the Diamox and being post-lumbar puncture, she's got a gradient of 6 millimeters of mercury across that stenosis. So we went on to perform venous sinus stenting, and you can see we've got reconstitution of that vein with a nice lumen following the stent, and we were able to wean her Diamox rapidly over a week to the point that she had completely stopped her Diamox, and 10 days post this venous sinus stenting, her IIH symptoms had resolved. She had no low pressure symptoms, and her Diamox side effects had resolved, and she was no longer taking any Diamox. So this is perhaps quite an exaggerated case, but a good case to remember rebound intracranial hypertension. This is a complication of treatment of CSF leaks, and it's a new type of headache that worsens when lying down. Patients will often report that this headache is completely different to the one that they had prior to treatment. It can be accompanied by nausea and blurry vision, so those typical symptoms of high pressure, and it typically begins within the first 36 hours after treatment. It's been reported to occur in between 7 and 27% of post-CSF venous fistula embolization. And the management of this is to elevate the head, to commence oral acetazolamide, and in severe cases, you may need therapeutic lumbar puncture. So we've started to consider prophylactic post-op Diamox in patients who we think might be high risk. We'd usually give them 500 milligrams at night and 250 milligrams in the morning for 2 to 4 weeks. And the patients that we tend to think are going to be high risk are the ones with a history of IIH, or the patients who've really had very long-standing intracranial hypotension that has had a delayed diagnosis. The next type of leak is the type 4 leak. So this is the distal nerve root sleeve tear where the CSF is leaking out into the interstitium or fascia. We've not actually had one of these at Monash to date. So I'm just going to show you the pictures from Richard Farb's paper where they actually described this type of leak. And what you can see here is that the CSF is leaking out into the interstitium rather than into the epidural space because the defect in the nerve root is beyond the epidural space. So these patients need to be imaged with the site of suspected leak down, and again, you'll see the CSF collecting distally, but I don't personally have a clinical case of that. So those are the 4 classified types of CSF leak. I'm now going to show you an example of sacral CSF leak because definitely from that paper in 2023 and now the updated paper from 2026, I think it's one type of leak that we're going to start seeing more and one that is going to start to be recognized more. So this is a 37-year-old female. She was lifting a heavy pot at work and she felt a popping feeling with discomfort in her lower thoracic spinal region. She then developed a headache that night and she found that that headache was worsened when she was in an upright posture. She also had this vague sense of disequilibrium and double vision when she looked to the left. She'd had epidural blood patches with transient improvement in the symptoms, but her symptoms always came back. Her HIT-6 score was 63, so moderate headache, but her MOCA score was 25 on 30, so she definitely had some cognitive impairment as a result of this. When we look at her MRI brain imaging, she had a burn score of 7, so again, a high probability of a spinal CSF leak. And when we looked at her MRI spine, what you can see is this spinal longitudinal epidural collection that is localized to the sacrum. It doesn't extend higher. So this is the classical imaging findings of a sacral leak in these patients. We did a DSM and a CTM, and you can see here all of this contrast that's pooling in the epidural space within the sacrum, confirming the finding of a sacral leak. She had targeted fibrin blood patching and non-targeted high-volume epidural blood patches, and this did resolve in a resolution of her SLEC. So this MRI is the post-treatment MRI. This is the pre-treatment MRI where you can see that SLEC. The patient remained symptomatic but improved, but unfortunately she's actually just recently represented with worsening of symptoms, so she's actually going to have attempted surgical repair of this leak. The last case that I'm going to show is not actually a spontaneous intracranial hypotension case, but I think it's a very nice case of a CSF leak and has some nice discussion points. So I'm going to show you an iatrogenic CSF leak case just to finish up. So this was a 12-year-old girl who had T12 to L3 scoliosis correction surgery at a different hospital. And 4 weeks after her treatment, she developed frontal headaches that were significantly worsened when she was sitting up. She has a past history of polycystic kidney disease, hip dysplasia, and hypermobility. Now, this was the MRI that was performed at the other hospital. And what you can see is these very grossly dilated venous sinuses and this pachymeningeal enhancement, which is in keeping with a low pressure state. And they did perform a CT myelogram, and you can just see here where that red arrow is, this extrathecal contrast in keeping with a ventral leak. So she got transferred to our hospital for management of that CSF leak, and we performed a targeted blood patch, which you can see here. And this is what happened. So on the top row, we have her pre-blood patch imaging, and you can see this dilated vein. Nothing very impressive about the orbits, and a pretty normal looking midline slice. And then post-operatively, unfortunately, she didn't tolerate being cannulated, so we don't have a post-contrast imaging. But if you look at the torcular and compare it to before it was very rounded, and now it's got its normal triangular configuration. And if you look at the optic sheaths before and after, you can see that those optic sheaths are now dilated, and there's flattening of the optic discs. And on the midline, we now have flattening of the pituitary gland, which is developed post-lumbar puncture. So keep those imaging findings in mind, because what happened post-blood patch was that she had a change in the headache characteristic, and we went to round on her. The comment to us was, I have a headache, but it's a better headache. So she preferred the high-pressure headache to the low-pressure headache, but it was definitely a different headache that was still there. She got fundoscopy, which showed grade 2 papilledema, and ultimately she was managed conservatively with her papilledema and headaches resolving over the following 2 weeks. And it was managed conservatively largely because she just could not tolerate the Diamox treatment. So in summary, I just want to give a few takeaway messages. Spontaneous intracranial hypertension is a debilitating but curable condition. Misdiagnosis and delayed diagnosis is common, but as we've discussed, increasing awareness is key and is the key to diagnosis. The MRI confirms the syndrome of spontaneous intracranial hypotension, and the spinal imaging allows to determine a wet leak from a dry leak and a SLEC positive from a SLEC negative leak, which allows you to plan the DSM or CTM to localize that leak. And that positioning for that procedure is determined by your presence or absence of a SLEC. I'll reiterate, don't forget the sacrum. It's not one of the 4 described types of CSF leaks, but I think it's going to be something that we recognize more of and we'll find more of because we're looking for it. Be aware of rebound hypertension and consider prophylactic Diamox. And certainly at Monash, we've seen that the multidisciplinary team is the key to success in these patients. I'd like to thank you for allowing me to present.
Yeah, thank you, Leanne. It's an amazing tour of this again, very underdiagnosed and potentially serious, as we saw that some patients unfortunately suffer without diagnosis for a long time. I don't see any questions in the Q&A, but I do have a couple of questions for you. I know that it's it's sometimes really the clinical, radiological, this is the easy part, right? But the question is, in patient with strong clinical suspicion of, intracranial hypotension, right? Low pressure, orthostatic headache. But some of those patients, they don't have the full imaging, like they have basically low Bern score. What do you do for those patients? Do you do just advanced imaging myelogram, or you do empirical patching or treatment before?
Yeah, so for the patients who we have a high clinical suspicion, and one of the things that I didn't talk about is particularly in the patients who have had CSF leaks for a long time, sometimes their MRI findings can start to normalize. So we know that there is a portion of patients who will have a low Bern score, but who will have a CSF leak. They're not common, but in those patients, what we tend to do is, if there is we'll still do the spinal imaging. If there's no SLEC, then typically what we'll do is we'll do a CT myelogram with the both lateral decubitus positions. If they have no CSF venous fistula demonstrated or no lateral leak demonstrated on that imaging, we'll usually do an empirical high volume blood patch and see what their response is. But we don't tend to investigate them beyond that, because generally speaking, the patients who've had high clinical suspicion and normal MR who have been positive, we've found the CSF leak on that CT myelogram.
Mm-hmm, mm-hmm. And when you do the blood patch, or actually when you do you actually do LP, just like opening pressure? Do you believe in opening pressure as diagnostic tool for those patients?
Yeah, so we do the lumbar puncture once, but we tend not to repeat the lumbar puncture because otherwise you're just repeating the you're giving them more risk of low pressure headaches. We have done one where they had clinical presentation suspicious for low pressure. We did the lumbar puncture and the opening pressure was 30, and that patient then got worked up for IIH. And I think it's important to note that there is a lot of crossover in the symptoms between CSF leaks and IIH, and that can sometimes make it difficult to differentiate between the two. So we do at least one lumbar puncture on these patients to confirm the pressure, but we tend to do that lumbar puncture at the time that we do the CT myelogram. So we try and make sure that when we do the lumbar puncture, we're actually doing it for a diagnostic purpose rather than just puncturing the theca with no designated purpose.
Right, but then when you do the LP, how often do you see like the opening pressure is really low, right? Like sometimes it's like even with all clinical and neurological, but their opening pressure is actually not low, right? Like it's within normal range.
100%. And again, that's why the symptoms can normalize, and particularly in those patients who've had very chronic leaks. So the reason that we'll do it at the time of the CT myelogram is that we will do, in anyone who we've got high clinical suspicion, we will do a CT myelogram on all of those patients just to rule out a CSF venous fistula. So we'll do the lumbar puncture at that time. And if it's normal, we will still do the CT myelogram at that time.
Okay, yeah, makes sense. One last question, which is I think in my even like clinical practice, with patients with clinical radiological CSF leak, you do the dynamic, both sides either the same day or at different days, but you still don't see the fistula, right? The CSF venous fistula. They are SLEC negative, you don't see that longitudinal, but you see a lot of diverticulum, and this is what's really very interesting. How do you interpret those spinal meningeal diverticular, right? You think this could be the source of the leakage, or are you think it like they are secondary, the cause or the consequence of the leak, like those CSF diverticulum that sometimes we see them in normal patients, like getting MRI of the spine for different reasons, but with patient with leak without fistula, how do you interpret those, and do you think they are the cause or the consequence of the leak?
Yeah, so these are the really tough patients, especially when they've got diverticular everywhere, because you can't even just focus on one side. So there's a few different ways that we deal with them. If we have a high suspicion that there is a leak, we'll usually repeat the CT myelogram at least once. And what we will do with those patients is we might pressurize them more. So we'll either give them a bigger load of contrast or give them more time, because the other thing is that when they've got these big leaks, our theory is that it's like a capacitance. It's just holding contrast, and you have to fill those cysts before you're going to see the leak. And if they've got multiple of them, that contrast takes longer to fill. So in some of those patients, if we don't see it initially, we might bring them back and we'll do a delayed run on our CT myelogram. So typically we do 3 passes, but we might do a 4th and do it a little bit more delayed. If the patient happens to have 1 or 2 that are particularly irregular, we might do a targeted blood patch at that level. And if they get a good response, then we will target that level. But, I think that the thing about this whole area is that it's such a growing area that we're still learning. We're refining things as we go. And just as we think that we've figured it all out, we'll get a patient that doesn't follow the pathway that we have, and we have to modify. And recently the example was exactly what you described, a patient with just big cysts everywhere, and we're going to bring them back and try and fill the cysts and then hit them with the contrast to make.
We have a few questions from the panelists as well. Dr. Liu, would you like to ask something?
Yeah, thanks, Prof. Lian, for a very nice and comprehensive lecture. I just have a couple of simple questions. First one, that while we know that to diagnose intracranial hypertension is quite easy, we are quite clear, but do you have any non-invasive modality helping us to diagnose low intracranial pressure, intracranial hypotension? For example, if you can again use the nerve sheath diameter looking at the as one or parameter, or there's any other parameter that convincingly you can use it and to tell your radiologist now I suspected CSF spinal leak, that I need an MRI. So I find it's difficult to convince somebody for that. And then secondly, the indication for surgery. And do you think that it must be mandatory to have a symptom such as headache or dizziness, and the symptom will change either in erect or supine position for you to decide whether this patient does need a treatment or not? And thirdly, third question, you do have a dilemma after treatment where patient have reverse problem from hypotension become hypertension. Based on your experience, how do we get about, do you actually ask, during consent, do you tell the patient, no, you may have intracranial hypertension as complication, and how you go about it? Do you have any tricks that help you to reduce the risk of intracranial hypertension? Thank you.
So first question with regards to markers for low pressure, we're pretty lucky that we just get the MRs and we haven't found, we don't have any other great markers. There are non-radiological markers that are being worked on to try and identify CSF leaks, because I think the hardest ones really are the CSF venous fistulas, because all the ones that are SLEC positive or that have fluid, you see the fluid collection and it becomes quite easy. We do use the burn score, so a lot of the patients who come to Monash will have had an MRI brain somewhere else, so as soon as they've got a burn score that is moderate or high risk, we have no issue getting the scans. But unfortunately, I don't have any other great markers of low pressure to try and convince a department to do the scans. The second question was about the surgery. Yep. So if we have a patient who, so for us, surgery is reserved for nerve sleeve defects and for ventral defects. If a patient has a SLEC, and both those cases should be SLEC positive, but they're not symptomatic, we will give them a high volume blood patch and we don't send them to surgery. So surgery obviously still has an invasiveness to it. And if they're not symptomatic, we will try blood patches. But if they fail the blood patch or they subsequently present symptomatic of the low pressure, they go straight to surgery. We've tried fibrin glue for these, we've tried high volume blood patches, and even the patients who we get a temporizing result, they eventually recur and they have surgery. So if they come in with bad symptoms and have a ventral dural tear or a nerve sleeve tear, we send them straight to surgery. We don't try and patch them unless they've got minimal symptoms or they're not keen on surgery. And the third question about consent, I consent every single patient for rebound hypertension. I tell them that the night of the procedure or the day after, they might have this terrible headache that they've never experienced before. The case I presented, she knew exactly what she had because she was originally an IH patient. But it's actually quite interesting. A lot of the patients who we treat, they're really excited when you round on them the next day because they go, I've got a headache, but it's different. And they're so happy because they've got a high pressure headache because you've told them to look out for it. And they see it as a marker of success. I do tell them that I may need to put them on Diamox. And if I have the very first CSF venous fistula that I treated in Monash had actually been leaking for 12 years and was having recurrent car accidents because she was blacking out. I did warn her about rebound hypertension and I actually did put her on prophylactic Diamox and she ended up on quite a big dose before I could reduce it. And it just helped manage that expectation because if you don't consent for it beforehand and they get the headache, they think you've just made them worse. So I tell every single patient that they might get rebound hypertension.
Yeah, thanks. Just to add on the last comment, because we do now know that one of the treatment for benign intracranial hypertension is to create the fistula endovascularly. So would you do that for this patient where long-term does not respond so much to a Diamox?
Look, I think, things like e-shunts are coming and I know that they're currently promoted for normal pressure hydrocephalus, but I think things like e-shunts are going to have a role in these IIH patients. So I probably wouldn't create a fistula or a deliberate leak because as you saw in my patient who was an IIH, they can become SIH patients, and that can become problematic. But I think I think that the technologies are evolving, and I think things like e-shunts in the correct patient, venous sinus stenting is probably going to be how we manage that IIH group.
Yeah, thank you very much.
Thank you.
Great.
Thank you.
We have a question from the audience. So, for patients with both IIH and IIH features and confirmed CSF venous fistula, how do you decide whether the leak is compensatory for underlying venous sinus stenosis versus the primary pathogenesis? And how does that influence the timing of embolization versus venous sinus stenting? Yeah, that's a tough question.
Tough question and tough patients, but unfortunately a reality, as we saw in my patient. I think that the answer to that is that the symptom that the patient is presenting with at the time is probably the one that you get addressed first. So you saw in the patient that I presented with a CSF venous fistula, she had untreated venous sinus stenosis. She almost self-treated herself by creating a fistula and became a low pressure patient. And actually at presentation, she had no stenosis to treat. So we treated the CSF venous fistula, and when the stenosis recurred, that's when we dealt with the stenosis. So I think it's not necessarily an answer based in science, but more so based in experience. I'd say you treat the symptom that is more severe, or the condition at the time that is most severe. And if the alternate rebounds, you then manage that symptom. But I think there are a group of patients who, when they have a new CSF venous fistula occur, you do need to check to see, are they an IIH patient and do they have a venous sinus stenosis that needs to be managed in order to prevent them from continuing to pop new fistulas as their own sort of self-treatment of their IIH.
Yeah, but it's interesting because most of those IIH or secondary fistula due to the IIH, we typically see the fistula in, like the frontoethmoidal, we do like more cranial, intracranial, but how often do you see CSF venous fistula as a secondary or consequence of an primarily intracranial hypertension?
Yeah, so I've got the one patient that we've had that I can categorically prove she was an IIH, SIH, then back to IIH. One of the other doctors in Australia who's doing some of these has shown me a case of that. I know Matt Amons has one that did that IIH, SIH, IIH. I don't think there's enough numbers to say, because certainly the patients who have cranial CSF leaks, skull-based CSF leaks, tend to not have that syndrome of SIH. That syndrome of SIH tends to be reserved for the patients who have spinal leaks, and with where that pressure normalizes. So I think
Yeah, definitely difficult. We've all encountered those, borderline or overlapped with, different presentation. Okay, great. I don't really see any other questions.
I would like to ask a few questions.
Sure.
I'm sorry for interrupting, but this is very interesting. I would like to ask, when do you commence treatment? Is it on table when you do a CTM that you have a leak and you do it right away? And in a non-targeted CSF leak, where do you give the epidural blood patch, and how much volume, and does the volume differ in cervical, thoracic or lumbar?
In terms of the CTM, for the vast majority of patients, we do the CTM, find the leak, and then treat. The exception to that, for example, we have a patient who has a lateral leak, and we repeated the CTM because we knew it was one of two levels, but we couldn't isolate it. So we repeated the CTM. And in that particular patient, we did do the blood patch at the same time because we had found the leak that we were looking for. But the reality is, when we do the CTMs, we end up with thousands of images, and looking at them before they've been processed, we know that you're not as likely to pick up those leaks than if you sit down with the processed images and scroll through them slowly. So we almost never do treatment at the same time as a CTM. We aim to find out where it is so that we give the patient the correct treatment for that. there are a few exceptions to that rule. And, you know, with the advent of photon counting CTs, that might change. You know, we might get better at identifying these leaks. We don't have a photon counting CT at the moment, but if we ever get one, I think that will be revolutionary. So that was the blood patches. Sorry, what was the second question?
Second was, what is a volume? What is a
yeah.
standard and what is a large volume?
Yeah, so large volume, we aim to get 30 ml of blood in. That usually requires giving the patient some sedation or some analgesia and warning them that it's going to be uncomfortable and that it's going to be tight. That's if we're accessing in the lumbar spine, though. If we're targeting in the thoracic region, usually it's 15 to 20 mils. And if we're going lateral because we think we have a lateral leak, then usually it maxes out at about 15 mil of blood. But generally, we say as much as you can get in, up to 30 mil.
Right, thank you very much. Prof. Luma, would you like to ask something?
Doctor,
Please.
be waiting.
Yeah, Leanne, I totally agree with you, and be aware of the rebound hypertension. Yeah, because I met the same case. I remember a case transfer, a patient transferred from the ENT. He underwent the mastoid repair surgery with CSF leaking for almost 10 years. Yeah. After the fat repair, the patient, we observe CVA stenosis and also the hypertension. So we give the patient lumbar RP shunt surgery, so the patient recover well. So I think this point is very vulnerable. It's absolutely right decision. And my question is, you do the repair surgery, you go the endoscopic hemilaminectomy, or just inject some blood patch?
Yeah, so I'm not a surgeon, I'm a neurointerventionalist, so I don't do the surgery. I've got a really great spine surgeon who does these. Initially, he was doing hemilaminectomies, and now he's actually, for a lot of them, because we localize them so accurately, he's doing them between the dura, and he actually rotates the dura towards him and repairs them from the side. But I'd be lying if I say I can comment extensively at about the surgery, because I'm not a neurosurgeon.
Okay, thank you.
Thank you. Prof. Benes, would you like to ask something?
Not really. That was great lecture, just attracting to something which I feel is an underestimated field in neurosurgery. It's really important to highlight these borders of neurosurgery, I would like to say. So congratulations on the lecture. It was amazing.
Thank you. Thank you.
Prof. Abdul Kader, we can close.
Yes, great. Well, thank you, Leanne. It was really great. I think we all learned something new about this. And by that, we're going to conclude and move to our next speaker, Dr. Ma, who's going to talk to us about using hybrid surgery under guidance of electrophysiology and DTI to treat a huge AVM and the brain functional area. So
Right.
please go ahead, Dr. Ma.
I would just like to mention that this has been broadcasted on WeChat, YouTube, and Zoom. Thanks to Professor Shubin. And today we have around 575 people who have logged in through all the different channels. So we are extremely grateful. And for the second session, the chair is Professor Vladimir Benes. So I'd like to hand over the podium to him to move ahead. Prof. Benes.
Well, thank you, Raja. But I think that everything has been said, that we all are looking forward to the lecture about the AVMs, which probably we do not treat much. So please, Professor Luma.
My topic is using hybrid surgery under the guidance of the electrophysiological and DTI to treat the huge AVM in the brain function area. Dr. Luma from Department of Neurosurgery, West China Hospital. This is my content. We come to the pathological anatomy and vascular structures. Most of the location of the AVM located at the functional area or non-functional area. The size maximum in diameter shown we can see on the MRI or the DAC, but most of the time we use the combination. The feeding artery can be divided into the single, multiple, deep penetrators blood supply. The draining veins includes the superficial or deep vein drainage, single or multiple, with stenosis, occlusion, dilation, or retrograde blood flow. Abnormal vascular cluster, we can see the different type, depends on diffusion, whether merged related aneurysm or AVA, whether to merge the venous outflow with the tract stenosis or occlusion. The clinical feature of the AVM, the onset age is most of the time is young, 20 to 40-year-old. The clinical manifestation we can see is intracranial hemorrhage, ACH and intraventricular hemorrhage. Some young people suffer from the seizure and other neurological dysfunction and headache. The natural history of disease, the risk of the hemorrhage on ruptured AVM HR is 2.2%. 10 years CHR is 16%. 20 years CHR is 29%. For the ruptured AVM, HR is 4.3%. 10 years CHR is 35. 20 years CHR is 45. For the seizure, 20 years incidence is 18. Is a little bit high, and for the neurological dysfunction, 20 years is 27. All cause mortality, we can see 20 years is 29%. So it's a very high risk disease. The high risk factor for the AVM rupture includes the history of hemorrhage, subpyral and deep AVM, associated aneurysm, presence of arteriovenous fistula, and stenosis of the venous outflow, and the AVM size. The treatment, I think I don't want to mention the treatment here too much because all of us know the microsurgical resection, stereotactic radiosurgery, like gamma life, endovascular embolization. But the different way has a different advantage, disadvantage, and complications. For the surgical resection, it's the most direct way. The advantage is a complete blocking of the lesion and immediately remove the hematoma and long-term efficacy. For the gamma life, and depends on, I think most of the time it depends on the size and the time. So for the endovascular embolization and in the hybrid OR, we always do the pre-operative embolization, reduce the intraoperative bleeding. So it's a very effective supportive measure for us. And for the assessment, I think it's very important for this part. We know most of the time we use the Spacer Martin scale. Now, grade 1, 2, the risk is very low. Grade 3, it's controversial. Most of the time we think the risk is medium, but 3A, the risk is low. For 3B, the size is 3.1 to 6 centimeters, and functional area, non-deep venous drainage, the risk is very high. 3C, the risk is very high. But now we also use as microlortin and Young's grading. It's a supplement. We call it as ACN microlortin and the Lortin Young grading. It includes age. Age less than 20 year get 1 point. 20 to 40-year-old get 2 points. Older than 40 year get 0.3. Now bleeding 0.0, no bleeding 1.1, compactness 0.0, for the diffusal 0.1. So we use as a combination. The surgical resection of AVM indication for the removal is a low-grade AVM. I think ACM grade 1 or 2, and advanced grades use more composite method, like the hybrid method. And another indication is a rupture of the AVM with ICP, even has a risk of the brain herniation. So the surgical resection procedure is exposure, there's a proximal control and separation of the lesion interface and ligation of eventually, and I think the last time, ligation of the joining vein. So the model monitor guided surgical treatment of the complex AVM. We retrospective analyze the clinical data and treat outcome of the patient who underwent resection of complex AVM assisted by electrophysiology, preoperative embolization, perioperative precise monitor at my center. The pathological anatomy, angioarchitecture, and clinical picture were evaluated to guide the individualized and the precise treatment. Key technical points included the intraoperative exposure of the arachnoid interface and carefully management of the immature deep preparators. 28 patients were included. The average diameter is more plus or minus 2 centimeters. The AVM was distributed in the critical brain region, including the basal ganglion, part of the thalamus, the central region of the frontal lobe, and the temporal lobe. And it was closely associated with the M1 and M2 segment MCA, and the long lenticular striate artery, the A1 and A2 segment of ACA, and their preparator, as well as a 7-vein complex. All the case was successfully resected under the multimodal monitoring, as confirmed by the intraoperative electrophysiology and DSA. We post-operatively, 4 patients developed mild neurological deficits. 3 patients resolved completely after treatment. The mean follow-up period was over 2 years and with no mortality. I show my case one by one. The case 1 is a left atromedial temporal lobe AVM. This is a 31-year-old male suffered from recurrent seizure for 1 month. The PE is negative. So we do the preoperative MRI scan. We confirm the AVM here on the left temporal lobe at tempopola. So the DSA, we come to DSA. We analyze the DSA from the anterior circulation. We find the feeding artery from the M1. We mark the M1 and the nidus and the drain drainage to the cerebral fissure. We also analyze the posterior circulation. We find the feeding artery from P3, and the vein, the drainage vein is to the lobby. This is a preoperative EEG. I show you the surgical procedure. Under the EEG monitoring, we open the cerebral fissure step by step until we expose a segment of M1 and M2. We expose the medial surface of the AVM first. We find the feeding artery from the M1. Now we get the temporary proximal control. I like to use this SQLab 700 and SQLab 710 mini clip. Once we confirm under the electrophysiological monitoring and the ICG, we can cut up the blood supply first. Go fast. Then we predict the status of the patient during the surgery. Later we do the anterior temporal lobectomy. We expose the lateral and the basal surface. We find the nidus here. Then we deal with the posterior surface of the AVM. We deal with the preparators in the white matter. We call the nidus circumferential, like a spiral resecting. I think the nidus should be resected circumferentially. So this is the post-operative CT scan. We choose left side nidus removal and lobectomy, and we can see the aneurysm clip here. Case 2 is a resection of the right frontal AVM with embolization. This is a 25-year-old male. He's a firefighter on seizure for 21 days. Basically, examination is negative. This is a pre-operative MRI scan. We find the AVM nidus located in the right frontal lobe with some perforators. We do the in the hybrid OR. We do the pre-operative embolization and the surgical resection. The DSA shows us the blood supply. We can see the blood supply can be divided into two parts. One part feeding artery from the MCA M4 from the lateral side, and the feeding artery from the ACA, and the early drain vein to the sagittal sinus. We also can see the dilated ACA here. So we make a plan. We embolize this ACA first. We use the onyx glue to embolize the ACA blood supply. Here, I have to explain why we embolize this ACA first, because ACA's distribution is in the deep side. It's very difficult to get the proximal control first. So it's in the deep side. It's not so easy to get the proximal control, but even though the lateral side blood supply is more, but I think it's very superficial. We can get a very good proximal control. So we embolize the ACA first. This is before blood supply, before and after embolization. Where after the embolization, we can see the blood supply goes down. And another key for this kind of case, we cannot embolize too much. Sometimes we do the embolization after the craniectomy. We don't open the dura, but we do the craniotomy first, and we embolize. It's safe. Or especially in the hybrid OR. And first, we open the arachnoid membrane, and we use a dissector to cut off the arachnoid membrane. We you cannot do the resection first, but we have to get a good exposure. We cut the arachno membrane circumferential, like the spiral resection, till we get the very good exposure, and we preserve the venous drainage. We cannot cut off the vein first. So now you can see I don't calculate any structure. I just use my scissor and my dissector to get a good exposure. Till we find a very clear demarcation. ICG to identify the blood supply from the MCA. Once we identify the blood supply, I use a mini clip for the temporary clip. Sometimes once we confirmed, we use a titanium clip. I use a Bible to calculate all the blood supply from the lateral side. Sorry. I like to use some carotenoid or the this is a preparator. You cannot for the preparator bleeding. You cannot use as a Bible to calculate because that's all is very weak. We have to use as a mini clip separately clipping, especially some blood supply from the lenticular striate preparator. It's very dangerous and it will bleed for a long time, and you have to track the bleeding point. Use as a mini clip separately to clip the bleeding point. Then we do the resection, and the last time we deal with venous drainage. This is a post-operative CTA. We find the AVM has been resected well. It says case 3 is a resection of the right frontal AVM after embolization. It's a 29-year-old male, suffered from the sudden limb convulsion for 10 days, and the physical examination is negative. We read the MRI scan first. We can find the AVM on the right frontal lobe, involving the frontal and next to the central sinus. This is a preoperative DSA. We can see the blood supply from the MCA and some small blood supply from the ACA. Very big venous drainage. So I like to use a 3D reconstruction to mark all the characteristics of the AVM. We mark the blood supply of the MCA first. I like to use a mark, and we identify the transit artery in the AVM in the nidus. I will also identify the aneurysm in the nidus and the aneurysm related to the blood supply, and confirm the AV shunt. And we can see the AV shunt, and here is the blood supply from the ACA. So I show you the videos. This is right frontal lobe. So in the assembly, we in the hybrid OR, and we embolize the AC blood supply first, and because it's in the deep side, it's very difficult to get very good proximal control first. I use as in the similar way with the last case. We open the main arachnoid membrane step by step, and I use a mini clip to get the proximal control of the aneurysm. Here we attack the inferior artery front. We get the spiral resection of the aneurysm. Here, this is yeah. For the bleeding, I like to use the mini clip. It's still a mini clip. Here we can see a cavity. So the patient may suffer from bleeding in the past. I like to resect the AVM with the past bleeding, because I find this kind of nidus, we can find a very good demarcation between the normal structure and the nidus. It's very natural. So we cut up the nidus. We use a Surgicel for the hemostasis. Okay. Another case is a little bit complicated. It's a resection of right basal ganglion AVM after the embolization in the hybrid OR. It's a 70-year-old male. It's a guy that suffer from the sudden dizziness with vomiting for 4 days. The patient also suffer from the IVA transit CT scan, but here I don't show the CT. I just put the MRI scan here. The physical examination is positive, and the preoperative MRI scan shows the IVH and AVM on the right frontal lobe and the chordae nucleus. Then we analyze the DSA first in the OR. We do the DSA first. We can see the blood supply almost come from the 3 parts. One part from the MCA, and we find some immature perforators here, and some from the ACA. So for the MCA part, we mark the 3 main feeders from the M1, 1, 2, 3. And on the ACA part, we mark the frontal polar artery and the perforator artery to the nidus. I like to use a 3D reconstruction to mark it well and identify everything, so we can get a very good control during the embolization. This is a DSA. We use onyx embolization. For this case, we open the dural. Do the craniotomy first. They open the dural, then we do the embolization because it's much safer. So I can embolize as more as possible. This is a surgical procedure after the embolization. We dissect the MC part. We also open the cerebral fissure first. Exposes blood supply. During this is M1. During the surgery, everything is is under control and on the electrophysiological monitoring. I use this mini aneurysm clip and the titanium clip. Alternatively, once we confirm this artery can be cut up. Because the nidus is under the cortex and has been embolized well, so we do the lobectomy. It's circumferential resection. Okay, now you can see the IVH of the patient. We remove the hematoma in the ventricle. We find a very clear demarcation, and the last time we cut off the drain drainage. So this is a monitoring report. So we immediately give the patient DSA reviews. We find the aneurysm has been resected well, and all the blood supply, all the blood is good for the raised hemisphere. This is a post-operative CT scan. We show the big cavity, the nidus and the giant AVM has been removed. This is a follow-up. The patient come to my outpatient 6 months later. Yeah, it shows no limb paralysis. But unfortunately, the patient suffer from infarction in the right side thalamus. But he recovered after rehab. Now, he's fine. This is AVM in the left central region. It's a 30-year-old male with limb convulsion for 5 years. The physical examination is negative. We can see the preoperative MRI scan. The AVM located and next to the central sulcus. So for this kind of case, it's very difficult. And we do the preoperative MI scan, and we also combine the DTI technique and mark all the functional fibers, pyramidal tract, and other functional fibers. This can describe the niders, the blood supply and vein drainage, and the surrounding structure, especially the AVM next to the functional fibers. We have to mark it first. So the preoperative DSA show is grade 4, and the supplement SM is 0.7. So we can see the blood supply from the MCA and from the lenticular stride artery, but the functional fibers is here. So we have to be careful for the resection. But we also find the intranidal aneurysm. So we do the embolization first and the monitoring after the craniotomy. So my plan is preoperative embolization and the surgical resection and the stereotactic radiotherapy, gamma life. Why I use gamma life? Because I think this part, especially the artery from the lateral stride artery cannot be removed directly during the surgery, because it will cause damage to the functional fibers. But sometimes it's very difficult. This is why I don't use too much BiPAP to coagulate the blood supply. I think for the large lenticular stride artery, I like to use as a aneurysm mini clip. This is a surgical resection after the surgery. We can see the MRI scan. This is a cavity. We also can see some residue in the deep side here. This is a residue of the niders. Here is functional fibers. We immediately review the DSK. It confirms the blood supply from the lenticular stride artery and the ACA, so we keep it during the surgery. So we plan gamma life after the surgery. And then we review the DTI. We find all the fiber was preserved well. The patient has no complication after the surgery. So I think the plan is very good for the patient. So we also have to mention the flow-related aneurysm. AVM flow-related aneurysm can be divided into two parts: the flow-related aneurysm and the independent aneurysm. And the flow-related aneurysm has a proximal or distal feeding artery, or inside the niders. This is proximal. That is a distal aneurysm. So this is my case. It's the patient. It's a AVM located on the posterior part of the temporal lobe. After the resection surgery, the flow-related aneurysm disappear, but the independent aneurysm also existed after the surgery. So we come to the summary. So application of the electrophysiological techniques, interventional, adjunct, and multimodal perioperative precision monitor enable the complete AVM resection with reduced mortality and the neurological deficit. MI and DSA are necessary except for the herniation. It's another condition. You have to save the life first. Even we do some craniectomy first. But I think the MI and DSA is very necessary. Then carefully review the dynamic DSA. I like to use the 3D reconstructed DSA to confirm the hemodynamics. After we mark all the hemodynamics, I will assist as and choose as optimal plan. And we also emphasize as management of the deep lenticular striate preparators. For the preparators, most of the time during surgery, we cannot use a Bible to coagulate. We have to use as a aneurysm mini clip to clip the bleeding point. Sometimes one-time clip is very difficult. I like to use the clip alternatively. Eventually we can find the bleeding point and install my clip well. And I think the over-embolization is not so recommended, especially if we choose as a hybrid surgery or hybrid OR for the patient. Over-embolization will result in the nidus hardening, and it's cause the surgery procedure difficult, or we have the higher bleeding risk. If the blood supply from the MCA and ACA, if we embolize the ACA too much, so the nidus become harder. It's very difficult to get the tract or exposure of the surrounding structure. And if we embolize the nidus too much, and some lenticular striate preparator or some other preparators will get bigger. So I think the blood hemodynamics will change, will cause a high risk of bleeding. So we have to avoid the overcoagulation in the ruptured venous aneurysm. Handle it last, because the venous drainage I think it must be the last step during the surgery, and or we also emphasize the maximum effort to preserve the function, and we also need the patient and persistent. Thank you.
Thank you very much, Professor. That was a nice lecture and nice series of great 3 AVMs. I would like to have a few questions.
Okay.
You do avoid basal ganglia and real eloquent structures surgically.
And I think depends on the different types. If the patient suffer from the ICH, I think we should be positive. If the AVM is unruptured, I think we should be careful. I plan to embolize it first and make the hemodynamics and the change. But I emphasize it again, we cannot embolize it too much, because it will cause the extra bleeding and the hardness of the nidus.
Yeah, that I agree. And did you see that even the embolized vessel bleed?
Embolized
with embolized vessel, you cut the vessel which is embolized and it still bleeds.
Embolized after cause the bleeding. I see too much cases.
No. You embolize the nidus partially, then you go for surgery. You hit the embolized vessel under your microscope, and when you cut it, it still may bleed. That's my experience. That
Yeah.
It's not always that you must be careful about it and coagulate even the onyx, actually. Then the
Yeah.
next, what is the reason to open the skull to perform craniotomy and then embolize? What's your
Okay.
rationale?
Okay. I think it's safer, especially for the big big AVM. It's safer because I think it's an alternative choice. You also you can embolize the uh, first, but you should be careful and observe the hemodynamics and observe the patient for 1 or 2 days, and 3 days later you can do the craniotomy. That's okay. But I think for the big AVM, if you don't want to, if you don't have the plan to get the total resection, your embolization should be very careful. Should be very careful. And because it's the treatment of the AVM in the modern time, and we should use a multi-model ways, and like the microsurgical resection and gamma life and embolize. You cannot be so uh, you know how to say then. We
Yeah.
should be careful, I think.
Yeah, we should definitely be careful because it's not really that malignant disease with 2.2 risk of bleeding yearly and 30% morbidity, mortality after the bleeding. It's not really that a bad natural course. So you must consider your risks of treatment, which is according to meta-analysis 7% for each technique, whether radiosurgery, surgery, or embolization, and you sum it up. So if you embolize once, one session, and then go for surgery, you suddenly have a risk of 14%, which is then difficult to beat the natural course. Do you know what I mean? That, 3 pre-surgical embolizations and 1 surgery, it's a 30% risk for the patient. And then I do not see any rationale for offering this to a patient because we are then no better than the natural course. Let's go forward, Professor. The perforators, feeders, true perforators like anterior choroidal and these vessels, I believe that it adds another point in a Spencer-Martin scale because it's really dangerous thing, and I always are very aware to offer surgery when these feeders are involved. And in your case, you have shown leaving a piece of AVM behind and going for radiosurgery. Honestly, was it really intentional?
It's, you see my cases? I'm sorry.
Yeah. But in one of your cases, you have shown the main bulk of the AVM resection after the embolization with all the monitoring, which is perfect, I believe. And you left behind a piece of the nidus which was fed by the anterior choroidal artery. And you went for radiosurgery after this. And I wonder whether really this approach was intentional to leave a piece behind. I would be very much afraid of that.
Yes. Yes, I agree. I agree with you. Yeah.
Yeah. You then have quite a long latent time after the radiation, and you do not have a proper draining from the remaining nidus, and that's very dangerous in my mind. And the next question, with the monitoring you use, it's perfect. And you are then clipping the feeders from the MCA. Did it happen to you that you clipped the artery with temporary clip and the monitoring deteriorated and you had to alter your approach?
Most of the time we can observe the the structure of the blood supply. Well, once I find that because most of the bleeding artery, the structure is different from the normal structure. It's very weak. It's very fresh rate. So we almost most of the time we can identify, but still even we can identify, we cannot cut up first. I use as a temporary clip. We observe the
So there was no deterioration. I have a rule which is a must in AVMs, that any vessel is considered to be en passage unless proven otherwise. So I would be afraid of clipping these feeders without seeing where they really go. Those might be the normal middle cerebral branches. You are not afraid of that? And then the monitoring would be really paramount. It would tell you, all right,
Yes.
now I have my clip on en passage vessel, or all right, nothing happened on monitoring, I can go ahead and cut the vessel. That's what I would enjoy very much. We do not monitor AVMs, I can tell you. Now we shall start because it's perfect.
Thank you.
Good. And we do not have anyone from the floor?
Not
To
yet.
ask?
Not yet. You can conclude. Not yet. You can give your concluding remarks.
Okay, so let me conclude first before Professor Luma. That was an excellent piece of work. The AVMs definitely are still a neurosurgical disease which should be handled multidisciplinary. And I believe that AVMs should all be treated in an institution where all three treatment modalities are available, and they should be treated the same way as we have the tumor board. We should have an AVM board where the interventionalist, neurosurgeon, neurologist, radiologist would meet and they would decide about the proper treatment protocol for AVM patients. And you've shown that this is perfectly true.
Thank you.
Well, thank you very much. Now we come to the concluding part of today's webinar. I'll end this officially on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both speakers of today, Dr. Leanne Slater and Dr. Luma, as well as the chairs, Prof. Abdul Kader and Prof. Vladimir Benes, for the time and support for the ACNS webinars. Special thanks to my co-host Dr. Libun Singh for joining me today, and also special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have 575 people live today on all the 3 different channels. So until we all meet tomorrow online, it is bye-bye from all of us. Thank you very much for joining.